Hi, my name is Nancy Flowers, the Dementia Project Manager for Rainbow Hospice and Palliative Care. Today's module is The Brain is Failing. What you'll learn in this module is dementia's effect on the brain and how it impacts function, how dementia is diagnosed, risk factors for dementia, current research in Chicago and the country, challenges for caregivers, and hospice eligibility. Let's start with the brain as the command center for the body. The brain controls our cognitive and motor functions by sending and receiving messages through the spinal cord and the central nervous system. The basic element of the nervous system, which allows all of this communication to happen, is the nerve cell or the neuron. In the brain, neurons connect and communicate at synapses where tiny bursts of chemicals called neurotransmitters carry information from one cell to another. To stay healthy, neurons must communicate with each other, they must metabolize, they must be able to repair themselves. What is dementia? Dementia interrupts the communication that occurs between the nerve cells by destroying the synapses and killing the neurons. Proteins called plaques concentrate around the neurons and block or interrupt the transmission of information between the nerve cells. Inside the nerve cell itself, tangles congregate and disrupt the communication as well. So then what we see with that disruption of communication is a group of symptoms that really reflect what dementia is. And what we see are changes in memory, changes in behavior, and changes in intellectual function. These changes are not necessarily part of normal aging. The changes affect a person's ability to function independently. It affects our ability to manage our day-to-day activities. It changes the way we relate to other people. It affects our ability to function as independent people. The majority of persons with dementia are over the age of 85. However, persons under the age of 50 can also develop a type of dementia called frontotemporal dementia. Here at Rainbow Hospice, we have cared for persons with frontotemporal dementia as young as in their 30s. How does dementia affect function? We see a noticeable decline in communication, in learning, in memory, in our behavior, and in problem solving. These changes may occur quickly or slowly over time. The progression and outcome of this cognitive decline varies, but is largely dependent on the type of dementia and which area of the brain is affected.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
How is dementia diagnosed? It's a process of elimination that includes a comprehensive workup to rule out other causes for the changes in memory and function. The process includes a review of patient history, medical evaluation, neurologic evaluation, cognitive testing, blood tests, and brain scans. The only definitive way to identify if a person has dementia is a brain biopsy, but this can't be done until after the patient has died. You can see the difference between a healthy brain and a brain with Alzheimer's disease. Many of our patients have prearranged to donate their brains to one of the regional research centers in Chicago, either at Rush or Northwestern, and may request your assistance to ensure that this donation occurs after their death. This information you will note in the alert button of our medical record. Let's talk now about the risk factors for the development of dementia. Certainly age is one of them, general health can be another, race, as well as mental activity, and obesity can all play a role in the development of dementia. The Mediterranean diet in combination with exercise has been shown in some studies to reduce the likelihood of developing dementia by as much as 35 to 45%. The Mediterranean diet is a plant-based diet consisting of fresh fruits and vegetables, whole grains, and replaces butter with olive oil. It also replaces red meats with chicken and fish, and allows red wine in moderation. Research continues to look for new ways to treat Alzheimer's disease. Current drugs that help mask the symptoms of the disease are Namenda, Exelon, Aricept, and Razidine. But there are promising new drugs in development that would treat the underlying disease itself. One drug that's currently in development would slow down the process that breaks down a key neurotransmitter. Another drug in development is one that would regulate the activity of another important neurotransmitter involved in learning and memory. Studies also show that non-pharmacologic interventions can show improved cognitive function, including brain games, puzzles, and learning a new skill. Now I'd like to shift to how we help families develop realistic expectations for the person with dementia. We've talked about how the brain affects the person's ability to make decisions and to think. That also affects their ability to walk, to take care of themselves, to make decisions. And all of those changes decline over time, and their need for care increases over time. Caregivers can become very frustrated and angry with the changes they're seeing. They may not understand why the person with dementia is not able to do what they had done in the past, and they may in fact believe that this is willful behavior, that the person is intentionally trying not to do things that have been routine for them up to that point. So one of the things they're going to turn to you as their hospice team is to help them understand what they're seeing, to help explain the changes in behavior and the way the person with dementia is responding to the disease process. They're also going to turn to you because they're going to have to make some very difficult decisions about care as the person's care needs increase. So they will turn to you, their hospice team, to help them in making some hard decisions. Does the person need more care? Do they need a change in location of that care? How can they help best support this person with their care needs? I'd like to talk about a patient that we cared for this past year, a woman named Mary, who was in her 90s, who was married with 3 loving daughters. Our hospice team had approached this family because they had noticed that Mary was experiencing difficulty with swallowing, and they were concerned that she was beginning to aspirate food into her lungs. So the discussion with the family had focused on a change in diet and the possibility of reducing the amount of food that we were providing to this patient. Not to shorten her life by any means, but to make it easier for her to eat foods that were pleasurable for her and more comfortable for her. The family struggle with this was that they were worried that if they made this change, that they'd be giving up on their mother. And so they were very uncomfortable with the recommendation initially and continued to feed the patient as if there were no changes in her swallowing ability. The staff asked for a dementia consult to help guide this family with some of this decision-making about swallowing. And so I met with the family at bedside while they were attempting to feed the patient. And one of the things that was quickly apparent was that she was struggling with swallowing, that she could not, in fact, swallow the food that was being placed in her mouth. It was pocketing in her mouth and dribbling out of her mouth. I was able to help point this out to the family and then to ask them a question that was really helpful to them in their decision making. One of the questions I asked them was if their mother had ever given them any kind of direction or any kind of comments about how she would like her care approached at end of life. And one of her daughters thought for a moment and then said she would have wanted this over 2 years ago. That realization for the family, not our statement about what to do, but the family's realization that this patient would not have wanted to continue as she was very helpful to them in making some of the next steps, which was shifting to a more comfort food-based diet and led them to eventually reducing her oral intake to only mouth swabs, because as they tried to feed her the next day, the patient continued to choke, continued to experience difficulty with swallowing, allowing the family to really observe this and to make their own decision that continuing to feed the patient in this way was not helpful to her in the long run. One of the behaviors I now want to focus on is something called sundowning, or late afternoon confusion. This is a behavior that can be very challenging for families and may result in the decision to place the person with dementia in a long-term care facility. Sundowning presents with increased confusion, aggressiveness, and frequently anxiety on the part of the person with dementia. You may see a person with sundowning behavior wandering or pacing and becoming increasingly fatigued. We do know that fatigue can be a significant trigger for sundowning. One of the things that we want to recommend is that if the person has been moved to a new or unfamiliar location, bringing in familiar items can help settle them, can help calm them down and help them have more of a sense that they're at home. Another thing that can be really effective for people who are exhibiting symptoms of sundowning is to play soothing or gentle music or nature sounds in the evening. Other things that can be helpful are reducing caffeine late in the day and generally keeping the environment as calm as possible, not having loud TV on. Things like loud noises can be very agitating to the person. If you believe that there's a medical condition that's underlying this behavior, this is a good time to consult with the patient's physician and to talk about possible triggers, which might be a urinary tract infection or sleep apnea. I'd like to talk about a woman now that we were working with this past year who was exhibiting signs of sundowning. She was living in her own home with the support of her daughter. Patient during the day was very calm, actually fairly functional within the home. Her language skills were fairly impaired, but she was still fairly mobile and able to engage with her family. As the day progressed, and as she became more fatigued, she would become more agitated. She would try to leave the home. She would try to go down into the basement, both of which greatly stressed her daughter. Her daughter, in fact, could not sleep at night. She was so worried that her mother was going to leave the home. And so one of the things we focused on during our consult visit was ways to safety-proof the home so that if her mother did get up at night, she would not find herself in an unsafe situation. And that included changing locks on the doors to key locks as opposed to a deadbolt lock, and also putting locks on both the inside and the outside of the basement door so that the patient could not find herself going down into the basement in the middle of the night. I now want to bring us back to the hospice eligibility criteria, the criteria by which we evaluate our patients at admission and throughout their time in hospice. So the patient is eligible for hospice admission when they meet the following criteria. The patient's unable to walk, dress, or bathe themselves without the assistance of another person. They're unable to swallow or refuse to take nutrition. They're incontinent of bowel or bladder. The patient has no meaningful communication, or the communication that you're hearing is very limited to just a few words during the course of the conversation. When you evaluate the patient using the FAST rating scale, they will have a score of a 7C or higher. In addition, in the past 12 months, they will have experienced one or more of the following conditions: aspiration pneumonia, a urinary tract infection, septicemia, pressure ulcers, particularly in stage 3 to 4, recurrent fever, another significant condition that suggests a limited prognosis, and the inability to maintain sufficient fluid and caloric intake in the past 6 months with the possible 10% weight loss or more. Now that you have a better understanding of the science of dementia and hospice eligibility, we'll move on to talking about helping families with decision-making at end of life.